Hello, my name is Naresh Gunratnam. I'm the medical director of the weight loss program at Huron Gastro, and wanted to talk to you about whether engaging in weight management in a GI practice would be feasible. And I'd like to just talk you through about how we do it at Huron Gastro and make a case for why I think gastroenterologists should be thinking about getting into the weight management field. Everyone understands that obesity is a national epidemic. 32% of men and 35% of women in the United States have a BMI of greater than 30. Now, troublingly, this has doubled between 1990 and 2008. And by 2030, it's projected that half the US population will be obese. Now, obesity affects every organ system, from mental health problems to pulmonary problems to sexual dysfunction, muscle and bone, nervous system, heart disease, and GI, and we'll talk about this in a little bit in depth. One of the things that I think people don't fully realize is that the epidemic of cancer, esophageal cancer, stomach cancer, colorectal cancer, liver cancer, pancreatic cancer, breast cancer, uterine cancer, ovarian cancer, thyroid, and bone marrow cancer all are linked to obesity. So this is something that I think is under-recognized, and I think we can impact as physicians. So the relative risk of many diseases are increased with obesity. Type 2 diabetes in men is increased almost 7-fold, almost 12-fold in women. Breast cancer is increased in women who are obese. Hypertension is increased 2-fold in men and women, and so forth. So once you are able to impact this one condition, obesity, you can have significant impact on all of these other conditions like hypertension, coronary disease, type 2 diabetes, etc. So this is a good bang for your buck disease. If you fix that one thing, then all these other downstream effects of obesity are also impacted. So what about the direct costs? Obesity is very costly. It costs our country about $169 billion in direct medical costs. But obesity is also more costly for employees. If you have a BMI of greater than 35, you consume 61% more medical costs than someone who's not obese. The good news is that to have an impact on disease states, you don't have to have significant weight loss. Only 10% of weight loss can make a significant impact in these disease states. Savings can be between $2,000 to $5,000 per individual. So losing weight significantly decreases cost of care to the individual. As we all know, obesity affects every organ system the gastroenterologists work with, including the liver. Non-alcoholic fatty liver disease is soon to be the leading cause of liver transplantation, liver failure, and cirrhosis, gallstones and gallbladder disease, colonic polyps, colon cancer, diverticular disease, disorders of defecation, esophageal cancer and reflux. The incidence of esophageal cancer is increasing more than any other cancer, felt to be due to reflux as well as cytokine production from central adipocytes, erosive gastritis and stomach cancer, acute pancreatitis, severity of pancreatitis, and pancreatic cancer, and small intestinal diseases. So as gastroenterologists, if we want to have an impact on all of these diseases, getting involved in weight management is going to be very important for us to do an adequate job in managing these diseases. You know, before I started doing this, if someone came in with severe reflux, I would double their dose of a PPI, but now I say the reason that you're refluxing is that your BMI is 35, and we're going to impact that as the root cause of your problem rather than chase your symptoms with more pills. And that's been very satisfying for a lot of our patients.